La siguiente plática de encefalopatía va a ser presentada en forma magistral por el doctor Jasmohan Bajaj. Es profesor asociado de medicina en la División de Gastroenterología, Hepatología y Nutrición en Virginia, Commonwealth University y también el McGuire Virginia Medical Center en Richmond, Virginia. Bienvenido.
Is it on? Thank you. Thank you so much for this invitation, and I'll try to speak slow. So hepatic encephalopathy is brain dysfunction caused by liver insufficiency and/or portal systemic shunting. It manifests as a wide spectrum of neurological and psychiatric abnormalities from subclinical alterations to coma. So the important point here is you don't need to have cirrhosis to have hepatic encephalopathy. The second point is not all hepatic encephalopathy is clinically apparent. So how do we actually, how should we classify the axis of hepatic encephalopathy? So one is very easy. You basically get the type, then you have grade, then you have time course, and see whether someone has a precipitating factor or not. So the type is very important because most of our things are C for cirrhosis. You have very few people who have acute liver failure. Grade, covert and overt, we are going to talk about this. Overt basically is what you can very easily diagnose as having hepatic encephalopathy, which is most of the hepatic encephalopathy that we diagnose in clinic. Grade 2 is when patients are disoriented but are not stuporous. Grade 3 is when patients are stuporous, and grade 4 when patients are have coma. Minimal in grade 1, no one knows how to diagnose. So it's easier in multi-center studies to make it as covert or overt. The time course is very important because with the reduction in varicose bleeding, hepatic encephalopathy is becoming a leading cause of readmissions. So episodic is 1 episode in 6 months, recurrent is more than 1 episode in 6 months, and persistent is that poor patient who never gets better. And last but not the least is a precipitating factor, yes or no. And these are all very important. So if someone comes to you with cirrhosis who is stuporous at this point, has come in multiple times with the same precipitating factor, ideally you should be writing in your chart type C, grade 3, recurrent hepatic encephalopathy with a precipitating factor. And this will force you to figure out where the encephalopathy came from and where it is likely to go. Because if it is the same precipitating factor that keeps on happening over and over again, the patient will never get better until you fix the precipitating factor. So what is the burden of cirrhosis and hepatic encephalopathy? And I'm going to quickly skip past these. There's a huge burden, at least in the United States. It's increasing by more than 10% per year. And this is the biggest cause for readmission, hepatic encephalopathy, followed by infections and renal and metabolic disorders. And you can see most hepatic encephalopathy is precipitated by infections and renal and metabolic disorders. And what's more importantly, if someone has cognitive dysfunction, it adds 7 points to their biological MELD score. So if hepatic encephalopathy was not taken away from the MELD score, like previously we used to have child score as the listing for transplant, which had hepatic encephalopathy. With the MELD score, this kind of went away. But it seems like now if you have a diagnosis of hepatic encephalopathy, that adds 7 points. So it is very important in the overall survival on these patients as well, even after they're recovered from an actual episode. Before we go to the overt hepatic encephalopathy, let's talk a little bit about covert. I'm going to talk very little because this is very important for our patients. It can tell you who is going to progress to overt hepatic encephalopathy. It more importantly affects the patient's quality of life. Because patients are not dying as frequently with varicose bleed, they are now living longer. And also with the advent of NASH, these patients are much older and much more comorbid. So therefore, it's very difficult for them to get transplanted. So therefore, their quality of life becomes very important because our patients are living longer, but they're not living better. So if someone has covert hepatic encephalopathy, that's a good way of treating them and making their quality of life better. It does affect driving. It affects overall survival and affects socioeconomic status. If someone is not feeling themselves, they cannot really do their job, and so they feel they are not able to earn as much. And it can be tested for. So what are the ways to test for? Obviously, there are many, many ways to test for, but the real world settings, you can do apps such as the Encephal app, you can do quality of life testing, you can do the inhibitory control test, or you can do an animal naming test, which is a very simple test in which 1 minute you write the number of different animals someone can actually take. But this is important for covert hepatic encephalopathy only, not the minimal, not in patients who are completely awake. These are in patients whom you don't know whether they have hepatic encephalopathy or not. And this is important because In this multi-center study that was just published in liver transplantation, 7 centers were given the same videos, patients who were normal, grade 1, grade 2, grade 3, and grade 4. And you can see here, this is the equivalent. This is the people who said yes in in everyone. The shaded ones are the non-trainees, and the clear ones are the trainees. You can see between grade 2 and grade 3, you can see grade 2 and higher, there was a huge concordance. Basically, everyone could tell who is grade 2 or higher. But grade 2 or lower, which means hepatic encephalopathy, which is normal, or grade 1, no one knew what was going on. So imagine a multi-billion-dollar trial in which the endpoint depends on whether someone has hepatic encephalopathy or not in one center, but in many centers. You need to have something that is grade 2 or higher to determine overt hepatic encephalopathy. Anything less than that makes it very challenging to reproduce and reliably do this. So what the things can do this better are these tests that we talked about. So if someone has potential hepatic encephalopathy, if they're disoriented, they have asterixis, they have somnolence, yes, it is clear that these people have overt hepatic encephalopathy. If not, then look at what setting your trial is in. If you're doing clinical practice in a single center trial, that means you know the patient, or you know the caregivers who can then tell you whether this patient is doing well or not. If the patient is not doing well, then clearly the patient has overt hepatic encephalopathy. If not, you should consider further specialized testing that we just talked about. If it's a multi-center trial, anything short of this is not acceptable as overt hepatic encephalopathy, because there are too many unreliable criteria to diagnose grade 1 or diagnose even normal. So now that we talked about covert hepatic encephalopathy, which is present in a lot of people, which is difficult to diagnose, but it's worth diagnosing because these people do very poorly from a socioeconomic and a societal perspective, let's talk about overt hepatic encephalopathy. This is the encephalopathy that we are usually comfortable with. We know when the patient has it. There can be two parts of this. The first part is when the patient comes in acutely inside the hospital or to your clinic. And the second part is when the patient is getting better, now you want to prevent recurrence. So the things to ask, every time a patient comes in, every time you have to ask these questions, however many times the patient has come to you, because this time might be different. Is it really overt hepatic encephalopathy? Is the patient's airway safe? What is the precipitating factor? Remember the 4 axes we talked about. What is the grade? What is the time course? And what precipitating factor, yes or no? And has the patient become alert after treatment? And if not, why not? So what are the treatment goals? We want to treat the precipitating factors. We want to make sure that the patient gets better in the acute episode. And of course, because it is hepatic encephalopathy, we must really start considering this patient for liver transplantation. With the episodic HE, when the patient has gotten better, our focus is now shifted to improving their daily functioning so that they're not a burden on their caregivers, prevention of recurrent episodes, and again, evaluation for liver transplant. Somehow we forget, just because it's not part of the MELD score, that this is not a relevant contributor to their overall risk. Remember, it adds 7 MELD points to their under thing if you were just counting survival. So it is important for us to keep liver transplant in mind whenever someone has hepatic encephalopathy. How do you know if someone doesn't have hepatic encephalopathy? Just because someone has cirrhosis and has altered mental status doesn't necessarily mean that they have hepatic encephalopathy. Things that will tell you that this is not really HE is new focal deficits, because HE is a generalized disorder. It's not a focal disorder in most cases. If someone has excitatory motor activity, such as seizures, if someone has current or recent alcohol use, current or recent illegal or even legal sedating drug use, because in the United States, opioid epidemic is rampant. It's an epidemic that can precipitate encephalopathy, but not really hepatic encephalopathy. In addition, many of these patients have changes in their sleep-wake cycle, so they take things such as Ambien, Zolpidem, etc. to help them sleep, which is not metabolized very well by the liver, therefore it bleeds on to the next day. And of course, other situations if the HE is unlikely, the patient has Parkinson's disease, patient has dementia because of other reasons, then of course you have to keep an open mind. So every time someone comes in with a confusion state in patients with cirrhosis, just make sure that these patients could have other reasons as well. What are the differential diagnoses? Of course, as we talked about, many of these patients have diabetes now with NASH. Anything related to diabetes that can cause encephalopathy can be participant in this. Alcohol and drugs, which we talked about, and electrolyte disorders that a previous speaker very elegantly mentioned. Last but not the least, intracranial bleeding and stroke is very important. Again, because of the NASH epidemic, and also because many of these patients with alcohol can have a subdural hematoma that can last in their body for a very long time before actually becoming apparent. So, hepatic encephalopathy is one of the most common reasons for altered mental status, but it's not really the only reason for that. So how can you make this differentiation in someone who's taking all these medicines? Make sure you you actually go over all the medicines that they take, because hepatic encephalopathy and medicines can be related in two ways. Either they're taking too much of something that they're not supposed to be taking, or they're taking too little of something that they're supposed to be taking. What are the too much? We talked about zolpidem and other things that make you sleepy, and of course things such as oxycodone and opioids. These go a very long way in causing sedation. Things that they may not be taking their lactulose, they may not be taking the rifaximin, or they may not be able to afford to take the lactulose or rifaximin, or they may have forgotten that they've taken the lactulose and rifaximin. So these things are very important every time someone comes in. What about blood ammonia levels? Please don't do them. They're not relevant. Your judgment is much, much better than any ammonia level can be. The only situation in which they are actually relevant is when someone is comatose and their ammonia level is normal. But there are many people with cirrhosis who walk around with high ammonia levels who do not have any overt hepatic encephalopathy, who then are treated with lactulose for the rest of their lives to treat their ammonia level, not their hepatic encephalopathy. So we are not here to treat people's lab tests. We are here to treat the people themselves. So if someone has confusion and their ammonia level is high or not, if they have all the other signs of hepatic encephalopathy, they should be treated as hepatic encephalopathy. So what are the treatments that can be used as an inpatient? Of course, lactulose is the first line treatment, but lactulose can often be very poorly tolerated. So in this NICE trial, they randomized patients into lactulose or the PEG prep that we use for colonoscopy, and they found in this very small trial, which has not been replicated yet, that lactulose was actually worse than the PEG prep. So in patients who can't tolerate lactulose or who have tendency towards anilius, you can use the PEG prep in these patients. What about lactulose and rifaximin versus rifaximin alone? And this is the survival, and this is the hospital day and stays. Group B is the patient who are only on lactulose, and Group A are patients on lactulose and rifaximin. These lactulose and rifaximin did much better. Again, one study needs to be replicated, but it tells you that there are things in which we can improve the current status of quo, which is lactulose. But importantly, the thing to remember in patients with hepatic encephalopathy is always treatment of the precipitating factors. Because if you do not treat the precipitating factors, you can throw as much lactulose and rifaximin on them and they will not get better. So what about prevention of recurrence of encephalopathy once the acute episode is resolved and the patient is now discharged? So how can we prevent this from happening again? Is the patient able to perform all the activities and instrumental activities of daily living? Basically, is the patient independent, or you need caregivers? Because caregivers are now your extension when the patient goes home. The caregivers are not someone that you must ignore. These are patients these are people whom you need to bring in when you're taking care of the patient, because without them, you won't get any of the information you actually need. And again, as we said, is the patient a transplant candidate? So after the first HE episode, lactulose is very important, because in this study from India, they randomized patients with one HE episode who had recovered into lactulose and placebo. Obviously, this is an open label study because the lactulose cannot be blinded. And it was very successful. But it's not always the case, because you have a lot of bowel movements with lactulose, and it requires a lot of training. Lactulose requires a lot of training. And there are also cultural factors. We just published an analysis of Indian patients versus American patients, and it found like Indian patients were more than happy to take large doses of lactulose because of a cultural effect which makes them want to clean their bowels constantly. Whereas Americans do not want to clean their bowels and they do not want to take lactulose. So there's a lot of cultural aspects that deserve much more attention, and I'm not sure what the situation in Mexico is, but this is something which is deeply cultural, and this is also a very social taboo, because you don't really want to ask people how many bowel movements they had. This is not a social acceptable conversation anywhere in the world. So you really want to make sure that before you prescribe too much lactulose or too little lactulose, that everyone knows what they're going to do. So for patients who don't do well on lactulose, we give them rifaximin. In this nice New England Journal paper, we randomized patients who were on lactulose to rifaximin versus placebo, and it was associated with a reduction in this recurrence of hepatic encephalopathy. Not just a reduction in recurrence, it was also a reduction in hospitalization. However, more than 60% of patients do not receive ongoing prophylactic therapy, and this is very, very problematic. At least in the United States, where rifaximin is very expensive, The cost is the major reason for this. But you may be shocked in your situation how many people are either not put on these medicines or are not taking these medicines because the importance of these medicines are not explained enough to the patients, and more importantly to their caregivers, because the patients sometimes do not remember they were actually encephalopathic. When they're encephalopathic, nothing, it's all a blank, it's gone. And when they're just recovering from this is when we push them out of the hospital, and then they get so much information. So it is the caregiver that really needs to be focused on. And if they are not convinced that their pesos need to be spent on this drug versus that drug, you need to want to make sure that they remember, they know the importance of these medicines, because these medicines can prevent their loved one from coming to the hospital. So how do we make this better? We can improve the setup, we can reduce the risk for recurrence, and we can encourage newer therapies. So there are systematic changes that can be done. These are very difficult to implement though. In this nice study done by Elliot Tapper et al., they randomized patients in 3 groups. Patients with hepatic encephalopathy got control, checklist, and electronic phase. And they found that if you had an orders checklist built into the hospital, that this has a much more compliance with preventing HE recurrence. But this is very, very difficult to do. A lot of patients with hepatic encephalopathy are nutritionally depleted, so they have sarcopenia. So you really must encourage them to do exercise, and not just exercise which means walking from their chair to the bathroom and back again. It is exercise that actually is isometric exercise, not cardio. Cardio will lose a lot of the fat, but it will not build a whole lot of muscle. What these patients need is muscle, because they are nutritionally and protein depleted, and that muscle is what will suck up the ammonia. What about the nutritional recommendations? Daily energy intake should be 35 to 40 kilocalorie of ideal body weight, not the gordo body weight, the actual body weight, the ideal body weight that should be, not the stuff that includes the ascites, NSRK or fat. What is the daily protein intake? This should not be restricted. 1.2 to 1.5 grams per kg per day. Do not restrict protein in these patients. And it doesn't matter what kind of protein. There have been studies done nice studies done from Mexico, that vegetable protein may be better than animal protein, and the lactose, etc., or eggs might be in between. But whatever the patient tolerates is better than something that you give and they don't eat. So get them nutritional, because nutrition is very important. Small meals or liquid nutritional supplements throughout the day, but more importantly, a complex carbohydrate snack during the night before they go to bed. Something like a granola bar or something, which is very important, because it reduces the starvation physiology. They don't continue to eat their muscle. What about the mind, now that we work the body? In this study that we did from our groups, in patients with cirrhosis with depression, sleep, quality of life, and caregiver burden improved after the patients and the caregiver were given mindfulness therapy. So you feel like this is all boring, this is all hoo-ha. At some point, when the patients are not transplant candidates, or they are really suffering from HE, but are really more suffering mentally than they are physically at this point, these things may be very relevant. Things such as yoga, meditation, and mindfulness are also an important tool that if you don't know yourself, there are plenty of apps, there are plenty of practitioners who do this that can at least help alleviate the mental burden of these patients and their caregivers. So what about that one patient or few patients who do not get better? You give them all the medicines, you appropriately diagnose them with hepatic encephalopathy. They could have shunts. They could have persistent intra-abdominal shunts. More importantly, more likely a splenorenal shunt. If a patient has hepatic encephalopathy and they have these shunts, you embolize them. The ideal candidate for this is someone who has a low MELD score, which is MELD less than 11, and one shunt. One large splenorenal shunt and a MELD less than 11. If your interventional radiologist can embolize them, the chances of them having recurrent encephalopathy episodes are much lower. What about fecal transplant? In this study that we did, we actually randomized patients with persistent hepatic encephalopathy and low MELD score. These are patients who are going to have a very poor outcome. Basically, these are not patients who are high up on the transplant list, and they have multiple episodes of HE. We took one donor stool sample, which was missing, which hit all the things that were missing in patients with hepatic encephalopathy, and we did an enema. And what we found in the FMT group, that these patients actually did better. Not only did they tolerate it, they actually had reduced hospitalization, improved cognition, and reduced HE episodes. And more importantly, this we just presented at DDW, this effect lasted for 1 year after the fecal transplant. This is exactly what you see in Clostridium difficile infection, one fecal transplant can make things better. Of course, it doesn't cure the cirrhosis, where like C. diff is cured after transplant, but at least the hepatic encephalopathy can get better. But right now, we are not, this is only done in 10 patients right now. We've just completed a study in which we've given them capsules, and we'll yet to find out how that's going to turn out. Last but not the least, HE disrupts the current caregivers' lives, and the caregivers are in a real problem here. Because you have to remember, your patients are not just the patients. Your patients are the whole family. Because hepatic encephalopathy affects the entire family. The patients cannot work, the family members cannot work. There's someone who has to take care of the patient constantly. So even a few words for the patient's caregiver can go a long way, and things such as mindfulness, etc., we talked about, are also important. So take-home messages. Hepatic encephalopathy is a spectrum from covert to overt. Covert hepatic encephalopathy can impair daily function, and early diagnosis using point-of-care tests are important. Overt hepatic encephalopathy staging along 4 axes to improve treatments and prevent readmissions is important. Appropriate use of therapies to prevent recurrence, improving nutrition, encouraging exercise, and treating the etiology is needed. Taking care of the caregivers is also important. In refractory cases, alternative diagnosis, embolization, and consideration for future therapies are needed. Thank you so much.